It's the early 2000s, and John is serving in the United States Army as an infantryman. He's on patrol carrying heavy equipment and supplies under a sun hotter than he's ever known. He and his team are hypervigilant, looking high, low, and in the middle for threats. But many threats are hard to see. Indeed, John would be attacked by unseen entities twice in rapid succession. The first would lift him off his feet and throw him to the ground. It occurred so suddenly that he didn't even know what happened until he heard muffled voices of his buddies and felt a medic cinching a tourniquet around his right leg. It was an improvised explosive device, basically an artillery shell rigged with a detonator, probably triggered by a cell phone. John was medevaced to a field hospital where the second attack would occur, but it was several days before anyone knew that this second attack even occurred. The hospital had prepared for this attack, not with sandbags, Hesco walls, mortars, or body armor, but with antibiotics. Battle wounds are dirty, ragged wounds, and infection is as dangerous as bullets and shrapnel, even more so in the case of certain bacteria like the one with which John would be infected. This bacterium, we'll see, has become a major concern for several reasons. One, it is highly virulent with a shocking case fatality rate. Two, it is hardy and can survive in hospital rooms, equipment, and on the gloves and hands of medical staff. Three, it is resistant to all but the most toxic of antibiotics. And four, colonized individuals who are infected but are disease-free can shed the bacterium and contaminate the environment around them, just like the most infamous of all colonized people, Typhoid Mary. But the bacterium we'll discuss today has a case fatality rate between 20 and 40 times greater than that of Mary's Salmonella typhi. John lay in bed, a sterile dressing wrapped around his thigh. For the first couple of days after the procedure to repair his leg, he felt as good as could be expected. He would heal and return home. But then he began to feel feverish. His nurses examined the wound, and they didn't like what they saw. The edges were red, the wound smelled foul, and there was notable and rapidly expanding inflammation. The surgeons examined the wound and found graying tissue. They needed to operate immediately to stop the advancing infection. Surgery for such infections involves debridement, the removal of dead and infected tissue, and often multiple surgeries are required to stop such infections. The medical staff hoped to save John's leg, but they knew amputation might be required to save its life. The reason the physicians were so pessimistic was the result of tests performed on the bacteria isolated from John's wound. The bacterium was brought into the lab and exposed to a raft of antibiotics one by one to determine which antibiotic would be used to treat the infection. A sample of the results reads as follows: Penicillins, resistant. Cephalosporins, resistant. Fluoroquinolones, resistant. And then the last resort, Carbapenems, resistant. The bacteria was filled with a host of genes whose products would ignore, destroy, or export the antibiotics. This was crab, Carbapenem-resistant Acinetobacter baumannii. John was transferred to Landstuhl Regional Medical Center in Germany, and then from there to the Walter Reed Army Medical Center in the United States. For months, John was closely monitored, underwent multiple additional surgeries, and was likely administered an antibiotic like colistin. Colistin is a member of the polymyxin family of antibiotics. These antibiotics poke holes in the membranes of bacteria, but have generally gone into disuse because they exhibit toxicity to nervous tissue, but most commonly to kidneys. But crab justifies these risks. The case fatality rate of crab is between 40 and 70%. That is, for every 100 people exhibiting symptoms of crab infection, somewhere between 40 and 70 will be expected to die. Gratefully, John was lucky. He survived and kept his leg, although it was substantially reduced in muscle mass due to the initial blast and the surgeries that saved his life. But how was John infected? Early in the 2000s, when the armed forces in Iraq were beginning to see these infections, which they called Iraqibacter, it was assumed that the dust, debris, sand, and other environmental contaminants of the blast carried crab into the wounds. After all, many other species in the genus Acinetobacter are environmental, living in soils and water sources. But Acinetobacter baumannii is more of an indoor bug, and its preferred environment appears to be healthcare settings. John and many of his fellow soldiers that suffered crab infections likely were attacked by the bacterium in the hospitals where they were being treated. This might ironically be because hospital environments are cleaned regularly. Not all cleanings of bed rails, etc. lead to the complete sterilization. The weak will be killed, but the strong can survive on occasion. Acinetobacter baumannii secretes compounds onto the surface on which it grows. That is, it grows in biofilms, and bacteria growing in biofilms are harder to neutralize with antibiotics and chemical disinfectants. But the cleaning procedures do a good job on A. baumannii's competitor bacteria, and killing the competitors gives A. baumannii more real estate to grow upon. And as John was moved from one facility to another, the bacteria also likely moved from one facility to another. While John's infection occurred in his damaged leg, A. baumannii also infects the lungs, blood, and surgical incisions. Community-acquired infection is rare. People become infected primarily in healthcare settings, notably intensive care units. Most likely, this is due to the poor health of the patients in the ICUs and the greater use of invasive medical treatments. Infection through contaminated catheters and ventilators are common routes of infection. In the 1970s, Acinetobacter baumannii infections, while potentially fatal, were relatively easy to treat. But now only a few combinations of old and new antibiotics are available to give the infected a fighting chance. This is in part due to the fact that Acinetobacter baumannii is quite promiscuous when it comes to exchanging genes with other species of bacteria. Now, any genes and alleles that help bacteria to reproduce in a given environment will be passed on to the next generation. That's natural selection. We've been using antibiotics regularly for about 80 years, but no new class of antibiotics, that is, a class that attacks a new target in bacteria, has been introduced since the 1970s. So the environment for pathogenic bacteria is full of relatively old antibiotics, and a bacterium that has acquired antibiotic resistance genes or has generated antibiotic resistant mutations will be the ones that populate the future generations. Thus, the rise in antibiotic resistance has been climbing almost exponentially since the late 1980s. A class of antibiotics that has played important roles in fighting bacterial infections are the beta-lactams. Indeed, the original true antibiotic, penicillin, is a beta-lactam. The core of these antibiotics is a four-membered beta-lactam ring, hence the name of the class. Beta-lactams bind to the penicillin binding protein of bacteria. This is an enzyme that the bacteria uses to build its peptidoglycan cell wall. Now, this enzyme is similar enough between gram-negative and gram-positive bacteria that the beta-lactam antibiotics can neutralize bacteria of both classes. Thus, beta-lactams are highly valuable, versatile, and powerful antibiotics. But bacteria did not first see these antibiotics when they were first marketed by man. No, these antibiotics have been around for a long time. They are natural products of certain fungi and bacteria. Remember, Fleming first found penicillin when he observed his bacterial cultures were being decimated by contaminating penicillium mold. So these organisms have been in competition for resources for vast amounts of time, and some have a particular facility for evolving antibiotics. Others have evolved a way to fight back by making enzymes that neutralize the other species' antibiotics. So in a relevant example, while some fungi and bacteria have evolved the ability to produce beta-lactam antibiotics, other bacteria have evolved to produce enzymes called beta-lactamases, which render beta-lactams harmless. You see, what we have here is a microbial arms war, and we've learned to use one side to supply us with antibiotics. But the other side, the pathogenic bacteria, are always fighting back with antibiotic resistance mechanisms. The history of antibiotic use is broadly stained with the emergence of antibiotic resistance. As antibiotics are introduced, used, and especially misused, selection for antibiotic resistance occurs and the appearance of resistant bacteria is all but inevitable. So let's take a look at the recent evolutionary history of Acinetobacter baumannii. This bacteria 50 or 60 years ago was treated with simple beta-lactams like ampicillin. But the development of resistance in Acinetobacter is rapid. And over the decades, physicians saw one antibiotic after another lose its effectiveness against the bacterium. What was left were the Carbapenems, a class of advanced beta-lactams that have proven effective even in the presence of some beta-lactamases. But the isolation in the 1990s of Acinetobacter baumannii that was resistant to a carbapenem antibiotic was met with terror and a new microbial acronym, CRAB, carbapenem-resistant Acinetobacter baumannii. But scientists are racing to keep ahead of the spread of CRAB. While there are several drug preparations in development, I will highlight two. One, sulbactam-durlobactam, a two-drug combination, and zosurobalpin, which is currently in phase 3 trials, and if approved, would represent the first new class of antibiotics marketed in 50 years. Sulbactam-durlobactam is marketed as Xacduro by Innoviva Specialty Therapeutics. The drug preparation is a combination of two drugs provided in one package for IV administration. Now, if you're thinking intravenous administration will make using this drug problematic, you really don't have to. The patient who has an active CRAB infection most likely acquired the bacterium in the hospital as a healthcare acquired infection. So the patient doesn't have to go anywhere. The nurses will start the patient's IV right in the hospital room or more likely in the ICU. Sulbactam is a beta-lactam antibiotic that has a trick up its sleeve. When beta-lactamases cleave the crucial bond in the antibiotic, the antibiotic covalently and irreversibly binds to the active site of the beta-lactamase enzyme. So sulbactam is a kamikaze of sorts. It sacrifices itself in order to inhibit the beta-lactamase, which would otherwise inactivate many beta-lactam molecules. And if the sulbactam does find its way to a penicillin binding protein, it can also inactivate that enzyme. So not only is sulbactam a beta-lactamase inhibitor, serving to fight the bacterial resistance mechanism, but it is also an antibiotic itself, helping to kill the bacterium by impairing cell wall synthesis. The addition of durlobactam to the preparation further restores antimicrobial activity to sulbactam, as durlobactam is a dedicated beta-lactamase inhibitor. So this is a very interesting strategy. Remove the bacteria's defenses and then go in for the kill. An exciting drug that is in the pipeline and has shown preliminary activity against CRAB is zosurobalpin, which is being developed by Roche and Harvard University. Zosurobalpin represents a brand new class of antibiotics called tethered macrocyclic peptides. They consist of 3 amino acids tethered end to end in a ring structure. This is a very narrow spectrum antibiotic, and if FDA approved, its initial use will certainly be directly against CRAB infections. Zosurobalpin targets a part of the gram-negative bacteria that has never been targeted before. The outer membrane of the gram-negative bacterium contains a substance called lipopolysaccharide, LPS. It's an essential part of these membranes and is also known as endotoxin. It affects people by basically overstimulating the immune system and can lead to septic shock, a bacterially caused drop in blood pressure. Crucial to the function of zosurobalpin, LPS is synthesized on the bacterial inner membrane, is moved into the periplasmic space, and then shuttled out to the outer membrane. Zosurobalpin blocks the movement of LPS, so LPS accumulates in the cytoplasm of the bacteria. There, the LPS is toxic to the bacteria itself as well. So zosurobalpin basically gives crab a fatal case of LPS constipation. And remember, this video is not nor cannot be considered medical advice. It is intended for educational and entertainment purposes alone. Decisions about healthcare can only be made in consultation between the patient, legal guardians, and trained medical professionals. Thank you for watching.